Female sterilization, multiparity, need of the permanent method of family planning, obstetrics, cesarean deliveries, medical diseases at a high risk of pregnancy, psychiatric problems, breast cancer, itching conditions, repeat the fetal malformations such as the hemophilia, RH incompatibility, Wilson disease, Tay-Sachs disease, and the Marfan syndrome. The interval surgery should preferably be done in the pre-ovulatory phase to avoid the potential risk of the pregnancy in the post-ovulatory period. For the contraindication, the young women less than the 25 years as dictated by the government of the India. Variety less than 2 children. As per this government rule, local infection, prolapse, tubectomy can be done at the time of the repair surgery. Methods of sterilization. Rhabdotomy, abdominal incision, extend will over the 5 cm and is done during the cesarean section and during the gynecological surgery. Pomeroy method. Fallopian tube is brought out through the incision and the middle portion is formed into the loop, which is tied at the base with the catgut and excised. Surgically reversible. Madeleine method. Loop of the tube is crushed and ligated. Surgically reversible. Irving method, mid portion of the tube is ligated and the intervening the portion excised. Aldrich method, femoral end is buried into the hole in the broad ligaments. Surgically reversible. Corneal resection, corneal portion of the tube is resected between the clamps. Yttrium method, tubal serosa is stripped off the muscular layer of the mid segment of the tube, which is then excised. Fibrectomy, excision of the femur results in the permanent sterilization and leaves no potential for the reversibility. Success rate following the tubal recanalization is low after the fibrectomy. Menuroprotectomy, safest. Pomeroy, Madeleine, Aldrich, Wichita, and the fibrectomy. Vaginal route combined with the Manchester repair operation for the prolapse. Higher morbidity and the mortality associated with the infection, higher failure rate. Laparoscopy under the LA or the GA. Pneumoperitoneum created. Bipolar cautery. The earliest cauterization technique has been now replaced by the elastic fallope ring, Halka clip, and the Filch clip. This S technique, hysteroscopy, has been abandoned because of the high failure rate and other complications of the uterine perforation, burn injury, and the infection. Complications will be like a shoulder pain, post laparoscopy, CO2 retention. Female sterilization is a permanent contraceptive method by blocking or removing the fallopian tubes. Laparoscopic tubal ligation is the most common method. Mediators valpingectomy is preferred due to the additional ovarian cancer risk reduction. Performed postpartum or during the C-section is requested. Failure rate, but failed sterilization increases the ectopic pregnancy risk. Reversal is possible but not always successful. Best with clips or rings. Long-acting reversible contraception (IUD) implants should be considered before the sterilization.